Hello everyone and welcome to our final session of Orthodontics webinar series. My name is Omar and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS, the largest global organization representing dental students worldwide. IADS brings together students from different countries to promote academic exchange, professional development, and international collaboration. This webinar series is organized under the SCORE Office of IADS, the Standing Committee on Research and Education, which is dedicated to advancing research, education, and global engagement. Through SCORE initiatives, students have the opportunity to learn from experts, participate in international activities, and broaden their academic experience. As this is the final session of the Orthodontics webinar series, we would like to thank all of you for your participation and engagement throughout the series. We sincerely hope these webinars have been insightful, inspiring, and beneficial to your journey. It's a great pleasure to welcome Prof. Elham today, and we sincerely thank her for joining us and sharing her expertise with us. Without further delay, I would like now to hand over to my colleague Emiliana, which will introduce our speaker and guide us through the session.
Good evening, everyone. On the behalf of the IADS, I would like to warmly welcome you to today's webinar. We are delighted to have you with us for a lecture on a topic that remains one of the most important clinical decisions in orthodontics, the time of treatment. Today's webinar, early versus late orthodontic treatment, evidence-based decision-making, will highlight the importance of accurate diagnosis and individualized treatment planning to ensure the best possible outcomes for our patients. It is now my great pleasure to introduce our speaker, Professor Elham. She is internationally recognized leader in orthodontics and dental education with an outstanding academic and professional career, spanning more than 3 decades. She is currently Professor of Orthodontics and Acting Dean of the College of Dental Medicine at Qatar University. She earned her Bachelor of Dental Surgery from the Jordan University of Science and Technology before completing her PhD in Orthodontics at Queen University Belfast in UK, followed by her orthodontic residency at the Royal Victoria Hospital in Belfast. She later obtained the membership in orthodontics and fellowship in dental surgery from the Royal College of Surgeons of Edinburgh. Throughout her career, Professor Elham has held numerous leadership positions in higher education, contributing extensively to curriculum development, accreditation, research strategy, postgraduate education, and digital transformation on dental education. She has authored more than 100 peer-reviewed publications, supervised numerous master's and PhD students, and has been recognized among Stanford University top 2% of scientists in both 2024 and 2025. A remarkable contribution to orthodontics research and education have also been acknowledged through several prestigious international awards. Beyond academia, she actively contributes to global dental community through leadership roles in professional organization, examination committees, and editorial boards of leading scientific journals. We are truly honored to have her with us today, and we look forward to benefiting for her extensive clinical, academic, and research experience. Thank you for joining us, Professor. I will leave you the floor now.
And thank you, Emiliana. Thank you for this great introduction. And thank you, Omar, and the IADS team for inviting me to give this lecture. I will try to now share my screen. I'm not sure I work okay, so I will start my lecture. I'm not sure do you see my screen?
Yeah, I see it. Okay, perfect.
Okay, so my lecture today is about the early or late orthodontic treatment. When is it the right time to do the orthodontic treatment for certain malocclusion? To start with, I want to declare that I have no conflict of interest to disclose. Yeah. So the agenda of this lecture is I will start with an introduction, and then I will provide evidence-based timing of orthodontic intervention regarding several malocclusion, including dental crowding, posterior crossbite, class 2 malocclusion, class 3 malocclusion, and vertical malocclusion. And I will end with the clinical recommendation, which malocclusions benefit from early treatment and which malocclusions better treated later. I will start with defining what is early orthodontic treatment. It refers to orthodontic intervention, which is carried out during the primary or early mixed dentition, usually before the age of 11 years, whereas the late orthodontic treatment refers to a single-phase comprehensive treatment, which is initiated at the early permanent stage and usually between the age of 12 to 15 years old. Now, compared to the with early two-phase treatment, what is the advantage of the late one-phase treatment? It is usually more efficient. It results in a shorter overall treatment duration, lower cost, fewer clinical visits, improved patient compliance, and reduced risk of patient burnout associated with the prolonged treatment in two-phase treatment. So, typically, we know that a comprehensive treatment is usually starting early permanent dentition stage. However, early treatment is still practiced, and geographic differences exist in its use. We have more orthodontists starting treatment early in the United States compared with the rest of the world. These differences reflect variation in education, orthodontic education, in treatment philosophy, and healthcare delivery system. So, in 1995, Janali reported that 1/3 of children undergoing orthodontic treatment in the USA were managed using a two-phase treatment approach. So, the optimal timing for initiating orthodontic treatment is subject of debate and controversy. And one reason for this controversy is that the accepted cost of the early treatment means that we have to do two-phase treatment protocol. So the lecture will cover the answer, or will at the end answer this question. Does the available evidence support the additional cost and treatment burden of early two-phase treatment compared to late single-phase treatment protocol? The lecture will review both sides of the issue of early and late treatment for the following malocclusion: dental crowding, posterior crossbite, class 2 malocclusion, class 3 malocclusion, and vertical malocclusion. So I will start first with the dental crowding. Which is better, to treat dental crowding early or late? All our discussion or our analysis will be based on this paper by Arnold, 1991. Who reported that 85% of children exhibited dental crowding during the mixed dentition stage. However, he reported that 73% of those children will have enough space if we utilize the leeway space. 11% of those will have residual crowding of 2 millimeter if we after utilization of leeway space. And also 16%, they have more than 2 millimeter of residual crowding after utilization of leeway space. So remember these percentages, please. Before going ahead, we need to know what is the leeway space. Leeway space is the difference in the combined mesodistal width of the primary canines and molars and their permanent successors, the canines and second premolars. The average leeway space, 0.9 per side in the maxilla and 1.7 millimeter per side in the mandible. So how do we preserve leeway space? We do utilization of leeway space by adding or by fitting lower lingual holding arch in the lower arch and by enhanced appliance in the upper arch. By doing so, we prevent the mesial migration of first molars into taking the deferent space, the leeway space. This way, remember that 73% of children who had crowding can be resolved by utilization of leeway space. So by doing this, we managed to relieve crowding in 73% of the crowding cases. What about the 11% who need, after utilization of leeway space, there is extra 2 millimeter of space? Now, extra 2 millimeter of space, it means that limited expansion of the arch, less than 1 or 2 millimeter of expansion. And this can be done easily and comfortably because expansion of less than 2 millimeter is reported to be stable. So arch development using lip bumper is a way to do arch development where there is proclination of lower incisor, distalization of first molars, and transverse expansion in the canine and premolar area. These are done by using a lip bumper. So overall, up to 84% of our patients, of crowded patients, can be treated successfully. First, by preserving the leeway space in 73%, and by arch development in 11% of the cases. This can be done by starting the treatment in the late max dentition stage, meaning 12 to 15 years. And therefore, based on these evidences, early treatment is not routinely required to relieve mild to moderate crowding. To continue with the crowding, what about the 16% of residual crowding with more than 2 millimeter after preservation of leeway space? Here, if we want to do early treatment just to avoid extraction, it is not going to do well because arch expansion of more than 2 millimeter is not stable. So we will not go for early treatment just for the sake of having non-extraction treatment. In this case, the treatment of choice either early extraction of the teeth with serial extraction, or we can postpone the extraction until the late stage with comprehensive treatment. Now, this article, the systematic review, suggests that early serial extraction or late premolar extraction, they produce similar relief of crowding. There is additional advantage for the serial extraction is that less relapse with early treatment, and there is a shorter active appliance wearing time. In this way, we have a conclusion or key message here regarding the dental crowding. Routine early orthodontic treatment to avoid extraction treatment is not supported by the evidence, by the current evidence, and late mixed dentition remains the preferred timing for most patients with mild to moderate crowding. And the third one is that patients with severe crowding should be managed on individual basis with treatment options, including serial extractions or delayed premolar extraction, should depend on clinical presentation. This is what is regarding the dental crowding. The second malocclusion that we are covering in this lecture is the posterior crossbite. Should we treat posterior crossbite early or late? Here, posterior crossbite can occur in the primary on the mixed dentition, and usually it can be unilateral or bilateral crossbite. The etiology of crossbite could be skeletal, large mandible, small or normal maxilla, or normal mandible, small maxilla, maybe due to soft tissues, mouth breathing, and habits like thumb sucking, and could be displacement, lateral displacement, like functional. Functional posterior crossbite occurs when there's discrepancy between mandibular and maxillary arches, and there will be premature occlusal contact. To avoid this premature contact, the mandible will shift laterally, and this will produce unilateral crossbite. One diagnostic feature for this functional shift is midline in the presence of unilateral crossbite. Once this happens, then we have to investigate the lateral displacement or functional crossbite. Why do we need to treat the functional crossbite? Usually it is associated with temporomandibular joint dysfunction, and patients also with lateral displacement are on the long term, it will affect the growth and development of teeth, muscles, and this will result in facial asymmetry. So for these reasons, it's better to treat functional crossbite early. Now, what's the management of posterior crossbite? Now, it is based on the cause. If the crossbite is based on resulting from a habit, then we have to do habit breaker, and habit breaker could be removable or fixed habit breaker. If the patient's crossbite is related to the mouth breathing habits, then we have to consult the ENT for adenodectomy. Also, if the crossbite is functional crossbite resulting from premature contact, we have option of occlusal grinding of the premature contact point. We have to do selective grinding. Or if the contact is severe or not little, we can go for occlusal only to raise the bite. Additionally, we have another option like expansion, and expansion can be done using removable or fixed, and can be slow or rapid. Slow expansion at a rate of 0.5 millimeter per week, and rapid expansion 0.5 millimeter per day. And here is the example of the slow expansion with removable. We have a jack screw and retained through the Adams clasp and C class, and usually we ask the patient to open the screw twice per week. And here is example of slow expansion fixed appliance quad helix, and this is fixed, and usually we activate it once per month. Another example of fixed is the rapid expansion appliances. We have the hard screw and we have the acrylic expander, and usually the expansion is 0.5 millimeter per day. So what's the evidence regarding the management of posterior crossbite in the primary dentition? It has been reported that in 2022, that 1 in each 10 children has a crossbite in the primary dentition stage. However, this crossbite self-corrects in 77% of children, which, as you can see, it is a big number. It's like 3/4 of the children that crossbite self-correcting. So when we see patients with a crossbite in the primary dentition, it may be wise to wait for eruption of the first permanent molar before attempting any treatment. What about the treatment or management of the crossbite in the mixed dentition stage? We have several randomized clinical trials that support the early correction of the crossbite during the mixed dentition. High treatment success being reported with the quad helix, removable appliances, and rapid maxillary expansion. However, current evidence suggests that quad helix provides higher treatment success and shorter treatment duration than the removable appliances. However, this rapid expansion produced greater skeletal effect than the quad helix. So what's the key message here regarding the posterior crossbite? Early crossbite correction is usually indicated, particularly if there is displacement. The displacement as it is opposed to occlusal wear, periodontal problems, and facial asymmetry. Am I going too fast or am I okay? Okay, so the third malocclusion that I'm covering in this lecture is class 2 division 1 malocclusion. Should we treat early or should we treat the class 2 late? Again, we'll go for the etiology of of this malocclusion. And the first etiology is skeletal, and usually 75% of class 2 is related to small mandible or a small and retrognathic mandible, while 25% usually is due to maxillary prognathism. Also, the second etiological factor, another etiological factor is the dental factors, which is the proclined teeth or retroclined lower incisors. And then soft tissues, we can see patients with a trapped lip trapped behind the upper incisors, causing them to procline and increase the overjet. Another reason for class 2 division 1 is the habit, like thumb sucking habit. It causes pressure on upper incisors and they procline, producing increased overjet. Now, management of patients with class 2 division 1 thumb sucking habits, as we did before, treat the cause. The patient needs to stop the habit, and if they can't stop it by their own, we have to apply a fixed or removable habit breaker. And usually they correct nicely. Now, class 2 division 1 with dental etiology, we have skeletal 1 malocclusion, and that's just the teeth are proclined. If the situation is ideal, like there's spacing and there's reduced overbites and class 1 molars and canines, then a robot retractor is the appliance of choice for treating this malocclusion. Management of patient with the class 2 division 1 due to skeletal etiology, like mandibular deficiency, then functional appliances like twin block and racing appliances are treatment of choice. And if the patient has excess maxillary skeletal problem due to excess maxilla, then the headgear is the growth modification appliance of choice. Another option for treatment, another treatment strategy is fixed appliance, and usually with or without extraction of teeth. Now, what are the arguments? What is the common argument for the early treatment of class 2 malocclusion? There's three arguments. One of these is three arguments. There is the greater orthopedic effect associated with early treatment. There is more reduction, and there's reduction in the risk of traumatic injury, and there is improved psychological well-being if we treat class 2 malocclusion early. So I will go through these arguments one by one and see what is the evidence, what are the evidence available. First one, does earlier intervention with growth modification appliance result in greater orthopedic effect? Here is the first one, the class 2 regarding the headgear treatment. A study by Weslander compared the result of headgears in patient early and late dentition stage, and they measured the effect of headgear on the maxilla, and it was 1 millimeter greater effect in the younger group, in the earlier group. But we need to say that the cost of this 1 millimeter is a two-phase treatment, which means a longer time of treatment. Now, the evidence regarding the more orthopedic effect with functional appliances using the Frankel 2 appliance. We have two groups. McNamara examined two groups, young group and older group, and they found that the older group has more orthopedic than the effect than the younger group. Another evidence here regarding early or late. Gianelli suggested that if treatment is started in the late mixed dentition stage, at least 90% of all children with the class 2 malocclusion can be treated in one phase, lasting 2 to 3 years. Another randomized clinical trial suggested that early treatment followed by comprehensive treatment on average does not produce two-phase treatment is no better than one-phase treatment. Here, the outcome of treatment efficiency. Here, treatment of class 2 division 1 is more efficient in one-phase treatment than two-phase treatment. And O'Brien in 2009, using the twin block, suggested that twin block treatment in children in early stage, children aged 8 to 9 years, has no advantage at all over treatment started at average age of 12 years. And the cost of early treatment is attendance, more attendance and length of appliance wear. Another evidence regarding the early or late treatment is the Cochrane review in 2014, which suggests that when functional appliance treatment is provided in the early adolescence, there are minor changes. There are minor beneficial changes. However, these are not clinically significant. Here's another one which contradicts the previous finding. This one published in 2026, and I found it by chance. I thought it is good to let you know about it regarding the timing of treatment in class 2, a systematic review. And this demonstrated that early treatment provides benefits: skeletal development, expansion, and airway improvement. However, Kevin O'Brien, who has an orthodontic blog, he was concerned about this paper, and he provided many major flaws in this paper. And I thought I will add it to you just to know about it in case you are faced with a reference or evidence which is not accepted by others. Kevin O'Brien suggested that 5 of the 8 papers included in the systematic review from the same study, and they used a risk of bias tool that is not compatible or that doesn't align with retrospective studies, and they only included studies after 2015. And this excluded otherwise studies, and also they did not take into account the Cochrane review on the treatment of early class 2. So please take care whenever you read this evidence. This is in respect to the evidence regarding more orthopedic effect when doing early treatment of class 2. What about the risk of trauma if we treat the patient early in class 2? Now, regarding the risk of trauma, the evidence before 2010 is that children treated with a two-phase treatment found no significant reduction in the incidence of trauma or injuries. Whereas Gianelli 2007 reviewed 500 patients and found there is no association between the overjet and the traumatic injuries. However, recent studies, numerous studies, has confirmed that increased overjet is a significant risk for traumatic injury. And children with overjet of more than 3 millimeters, twice the risk of incisor trauma compared to those with normal overjet. This risk also increased or threefolds if the overjet it was 6 millimeters or greater. Cochrane review in 2014 confirmed that early treatment significantly reduces the incidence of trauma compared with a single-phase treatment. And Coburn 2002, based on a meta-analysis, reported that the risk of trauma declined from 25% to 14% with early overjet reduction. Now, the third argument regarding the early treatment is, does early treatment provide opportunity to improve self-esteem at a younger age? And here the reference on the evidence is O'Brien who suggested that early class 2 treatment may provide short-term psychological benefits. However, these benefits do not appear to translate into long-term self-esteem when compared to treatment initiated later. So what's the key message here in class 2 malocclusion, early or late? Here is routine treatment of class 2 division 1 offers no advantage over treatment initiated during the growth spurt. And the second one, for most patients, single-phase treatment is more efficient, achieve comparable outcomes with less treatment time and cost. And the third one is early treatment should be reserved for selected cases, particularly those at high risk of incisor trauma or with significant psychological concerns. Coming to the fourth malocclusion, which is the class 3 malocclusion, which is better to treat them early or late. Going to the etiology of a class 3 malocclusion could be skeletal, resulting from small maxilla, normal or large mandible, or normal maxilla with a large mandible. Dental etiology, the upper incisors retroclined and the lower proclined, and postural class 3, anterior displacement class 3, where the anterior interference result in anterior displacement to avoid or mandibular anterior shift to avoid this interference, resulting in a class 3 incisor relationship while the skeletal pattern is class 1. Why to treat patients with anterior displacement? Fear of abrasion of upper incisors. Second, periodontal trauma to lower incisors. If not treated, they will develop into a true class 3 and the fear of temporomandibular joint dysfunction. These are reasons why we should treat the anterior displacement early. So what's the management of class 3 anterior displacement? Removable appliance is the first choice, where we can add removable appliance with double cantilever or anterior expansion screw. If the overbite is increased, we can add posterior bite plane to open the bite and procline the upper incisors. It's very important to know that at the end, overbite is the prognostic factor that will determine if the treatment will be stable. Fixed appliance 2x4 for treatment of a anterior crossbite is option for the patient, and we can disclude the teeth by adding posterior composite. Skeletal class 3, due to maxillary deficiency, we have protraction face mask, and usually the patient wear it 12 to 14 hours per day. And if the patient has class 3 caused by mandibular excess, careful monitoring of the growth is indicated to evaluate the progression of discrepancy and guide the timing of treatment. Another option or strategy of treatment of class 3 is the fixed appliance. Now, what's the evidence regarding class 3 malocclusion? Early or late? Franchi, in a long-term study, compared the patients treated in the deciduous and early permanent dentition with patients treated in the late dentition stage. And they found that more forward movement of the maxilla, more orthopedic effect was found in the early treatment group. Here, Wells et al. Evaluated the outcome, long-term outcome of patients with reversible headgear, and they reported that 70 to 75% long-term success will be there if treatment applied before the age of 10 years. Now, another study regarding the reversible headgear, it is most effective when it begins at early developmental phase rather than during a later stage. And the key message here is that functional class 3 should be treated early by eliminating the occlusal interference and correct the anterior crossbite to restore the normal function and growth. And class 3 caused by maxillary deficiency responds well to early treatment, which can improve maxillary growth and reduce the severity of skeletal discrepancy. What about the anterior open bite? Should we treat early or late? Prevalence of 17% or approximately 10% of children in the max dentition have open bites. This will increase in case we include the sucking habits. This will increase into 36%. The etiology could be skeletal, could be dental, or due to habits. And what's the management of patient with anterior open bites? As before, any habit counts should be stopped and treated. If not stopped by the patient didn't stop by his own, then we can apply removable or fixed habit breaker. Now, the patient is grower, and then we have growth modification with high pull headgear, or we can use fixed appliances, either 2x4 or full orthodontic appliance with anterior elastics. Now, what's the evidence regarding early or late? As we knew before, if the it's based on the etiology of the anterior open bite. If the etiology is a habit, then it's better to treat it early, and the patient responds very well. And in contrast to that, if the patient has a skeletal problem, open bite due to skeletal problem, we know that the vertical growth continues with age, and usually it is late in vertical growth. So it's better to be managed later with definitive orthodontic treatment in the permanent dentition stage. Coming to the last malocclusion, which is the deep anterior overbite, and the etiology of anterior deep overbite could be skeletal, could be dental, and could be soft tissues. And the management, usually removable appliance like Vitaplane for the patient, and another option is fixed appliance with bite turbos or auxiliary archwares or fixed appliances. What's evidence? Early or late treatment for the deep bite? In a clinical trial, comparing the outcome of deep bite management using Vitaplane and fixed appliance in patients at early stage or at late stage. We have evidence that no significant advantage of use phase 1 therapy in the vertical dimension. So the Bashiti et al. Concluded that deep bite management is best performed at puberty. So in conclusion, early orthodontic treatment recommended in patient with posterior functional crossbite, patient with class 3 malocclusion due to maxillary deficiency, patient with anterior functional crossbite, patient with the class 2 malocclusion with risk of trauma. And late orthodontic treatment is recommended in patient with dental crowding, class 2 malocclusion, skeletal open bite, and deep anterior open bite. And that's all. Thank you.
Thank you, Prof, for this insightful lecture. So we will start now with the questions. I remind everyone, if you have a question, to leave it in the YouTube chat box in order to pose it to the professor. So let's start. If the early treatment is not needed, and I apply the early treatment, what is the changes in the prognosis, basically?
No, it's not like changes in the prognosis. It is the patient. As I mentioned, there's a drawback for the early treatment. It doesn't mean it's bad. It's not bad. It's just that the patient will be into a long treatment time. Starting the treatment at the age of 9 and then continue until the age of 15. It's not easy to be cooperative later.
So basically, is it an over-treatment?
It's basically what?
An over-treatment.
Yes.
Okay. So let's go ahead. If you could give one practical piece of advice to dental students and young dentists about identify patients who need early referral, what would it be?
Yeah, I think any dentist, any general dentist doing the practice need to be aware of, need to practice well and have a good knowledge of treatment planning. Treatment planning will let them know exactly when to treat and when to refer the case. So this is my advice: is to master the treatment, diagnosis and treatment planning part of orthodontic education. It will help a lot.
So another question is about the management of the parents. How do you explain to the parents why a child needs a certain type of treatment and why, for example, they need different treatment than the siblings or the cousins and so on. For example, they know another child who had this treatment, an orthodontic treatment, but they need a different treatment. Or how do you explain and manage the parents in these cases?
Yeah, overall in orthodontics, we have 4 treatment strategies. We don't have more than these. One is removable appliance, the second is fixed appliance, the third is functional, and the fourth is surgery. So I think we are now talking about removable and fixed appliances. These are our functional appliances. It's based on the individual case, individual base. Whenever growth is needed, whenever we want to change the face and facial pattern, we are going for, and the patient is a grower, we go for functional. Whenever there is, for example, multiple teeth movement, many teeth to be moved, then we'll go for the fixed appliances. And if there is simple tooth movement, we go for removable appliance. And of course, some parents will ask for aligners, and these also need to be discussed regarding the cost and the availability of the treatment as well. So it can be explained easily based on individual need of the patient.
Okay, thank you. According to your clinical experience, what are the most common misconception among a patient and even young dentists regarding the timing of the orthodontic treatment?
It is not misconception. As I said, it's the educational, orthodontic educational philosophy. As I said, in the USA, they do a treatment early, so it is not like it's something not good, but it is the way they are doing it. So I wouldn't say anything regarding this question. I think it is like educational philosophy and the geographical areas where they practice orthodontics.
Okay. So we have, I think, one last question. If a pseudo class 3 malocclusion is converted into a true class 3, what would its management be? I don't know. Sorry. I repeat
Anterior
it.
displacement. If anterior displacement is converted into a true class 3, it will be managed as a true class 3. So we are now managing true class 3 case.
Okay. So I think we have reached the end of this webinar, and thank you so much for accepting this invitation and for joining us with this lecture. And I really appreciate that your insight in this in orthodontics. So I remind everyone to scan the QR code for the attendance. And
thank you, Mariana. Thank you. It's a great pleasure to be here.
Thank you so much for joining us, Professor.
Shall I leave now?
Yeah, thank you.
Yeah, okay. Thank you. Bye-bye.
Thank you so much. Bye.